منور يا استاذنا. Hi, Dr. Adham. نور الدنيا يا فندم. صفة كويسة ولا لا يا فندم؟ طيب عشان Okay, to save the time for Professor Dr. Adham. Okay, we must start. Thank you. Hello, Professor Dr. Adham. I will want to thank you about your appreciated time to this isolation time and this somewhat critical time in COVID-19. Professor Dr. Adham, one of the best nationally and internationally tutor in diagnostic musculoskeletal and neuromuscular ultrasonography, and also a famous rheumatologist here in Middle East. Also one of the president of the musculoskeletal and neuromuscular society here in Egypt. So I know his time and his effort today to accept our invitation. So the topic is knee ultrasonography tips and tricks. We start a little bit basics, not advanced talk. So I think I do live on our page. Floor with you, Professor Dr. Adham.
Thank you very much, Dr. Negma. It's really a pleasure to be with you tonight, and all the attendees, whether on Zoom or on the Facebook. I have to say first, Yani, I want to praise you because you're very scientific and active. God bless you. And I also want to praise the music. I like the music very much.
Yeah.
So today, hello, the attendees, everyone. It's a pleasure to be with you. We can speak about any joint regarding the ultrasound in different ways, different approaches, and different levels. So today I will be very practical, very basic, but I will open the floor at the end for any questions. I will pinpoint during these basic steps each area what trick or a mistake you can have a pitfall in, and feel free to ask anything you need at the end. Let's start. Just confirm that everyone can see the screen fully.
Yeah, it's well, yeah.
Okay. As usual, just as a mean of easing everything up, we would like to classify the knee or divide the knee into compartments: anterior, medial, lateral, and posterior. It's also a good way that you remember the steps and don't miss one area when you're scanning. So we start with the anterior exam. The anterior exam, we always put the knee in a 30-degree position, and the angle is calculated between the femur and the tibia, this angle here. So if you put something underneath, or if he just bends the knee, this is 30 degrees. This is the anatomy. So you have the skin, subcutaneous fat, quadriceps tendon, which inserts into the patella here. This is the cartilage of the patella and the suprapatellar fat. The other bone is the femur, the articular cartilage of the femur, prefemoral fat, and this potential space here is the recess of the joint. Okay, so if we say again, skin, subcutaneous tissue, quadriceps tendon, inserting into the knee. This is the cartilage of the knee. This is the femur with the articular cartilage, prefemoral fat, suprapatellar fat, and the recess of the joint, the potential space in here. If you translate this into the ultrasound, then it would be skin, subcutaneous tissue, quadriceps tendon inserting into the patella. Unfortunately, with the ultrasound, we don't penetrate the bone, so we don't see anything underneath. And here we can see the femur with overlying cartilage, black in color, and also a little bit of fluid in this potential space is also black in color, and this is the suprapatellar fat. You can have an image like this where you don't have any fluid, whether truly because it's a dry knee or because you're pressing a little bit on your probe. Here we have a little bit of fluid, either also normally or because you're pressing too little, which is good. We need to see a little amount of fluid, and we consider this an okay amount. Next step, each structure that you examine, we have to check in a two perpendicular planes. So we have checked the longitudinal plane. Now we rotate the probe 90 degrees. Rotation of the probe, first I want to show you this probe. Here is an ultrasound probe. So if you look at my picture, this is the ultrasound probe. Usually when the probe is working, when the machine is working, there's a light here, and the light represents the proximal part of the probe, and this is the distal part. So if you check the quadriceps tendon like this, then you are seeing it in a longitudinal fashion. If you rotate the probe like this, then it's a transverse fashion. This is called rotation, okay? So back again here, rotation of the probe or rotating the probe 90 degrees to the suprapatellar recess will show the femur, the bone. Anything that you see underneath the bone is an artifact because ultrasound does not penetrate into the bone. This is the articular cartilage. Articular cartilage, as you know, is hyaline and is formed of about 70-something% water. So it looks like jet black as the water would appear, except the fact that it is not compressible and it overlies the bone and it exists in certain anatomical areas. So if you put the probe like this over the femur, we are expecting to see a jet black cartilage echo. But here also, this small amount is the small amount of fluid that we have seen in the previous image in the longitudinal view. And this is the quadriceps tendon, and this is skin and subcutaneous tissue. Okay. This was the first step, and second step would be still in the longitudinal fashion. After we have finished the quadriceps tendon here, we shift to the distal area here to check another tendon that links the patella to the tibia, which is the patellar tendon. This is the patellar tendon. Patellar tendon has also a proximal part attaching to the patella here, and the distal part at the tibia attaching to the tibial plateau. So probably considering this image, we can see the proximal part and the middle part, and then you need to move your probe to check the distal part, which is very important to do this. And here I want to stop and also illustrate a trick. This tendon is very wide. That's why I put an angle on the medial and lateral sides to remind you that you have to move your probe. If you look at my picture again, as if this is the tendon, and we put the probe like this, so it's not enough to go proximal and distal. We have to scan medial and lateral to see all the width of the probe, because this is quite wide tendon. If you check it in a transverse fashion, you will confirm what I'm saying. From here to here is the width of the tendon. It appears very thin and with a shallow undersurface. I mean flat undersurface. If you get this surface as convex like this, then we are talking about a problem at the tendon. Okay, the tendon, as usual, would look very fibrillar pattern, well demarcated, sharp outlines, tightly packed, like spaghetti lines. Okay, this applies to all or most of the tendons in the body. Also, like so many tendons, it should be flat like this. If it's convex or rounded, then there's a problem with the tendon. Just remember this. The next step is still in the anterior view. So we have to bend the knee as much as we can, bend the knee, and we put the probe like this. So if If you look at my hand, we were straight like this. If you bend the knee like that, and you look a little bit like this tangential up to the femur, we look at the articular cartilage. It's a tangential view. I need to tell you a trick also. If you have a patient with major synovial effusion, he or she will not be able to assume this position. If you have a lot of fluid in the knee, the patient will not be able to flex fully. So you will not be able to get this view. Okay. What we can see here is the femur again in the undersurface. If you have
دكتور ادم بليز فور سوري فور انتربشن اعتقد ان لسه في صوره واحده بس اللي موجوده there is something wrong in presentation فاعتقد حضرتك اطلع من السكرين شير and then regain share the screen. Okay. Yeah. Great.
كده شايف ايه يعني؟
تبدا اهي. Still starting.
كده ظهرت؟
لا لسه. حضرتك اعمل stop sharing and then repeat the procedure again.
انا كده I stopped sharing. Fine.
Yeah. Again. يعني دي حصلت مع بروفيسور
في حد بيقول I saw all slides and images clear. يمكن انا خايف تكون المشكله عندك يعني.
لا الكونكشن عندي كويسه. طب حضرتك
هل كده اوكي ولا ايه؟ طب ممكن نسال البارتيسيبانتس يبعتوا لنا كده في الشات لو حد شايفين دكاتره. طيب can you see if the slides are moving؟ يعني this is another slide, this is a third slide. الصوت واضح والصوت واضح والصورة واضحة. Yes, I saw clearly.
Okay.
نجم الأمور عندك ماشية ولا إيه؟
لا أنا عندي الصورة still black.
طب تحب تعمل ريستارت ولا خطر؟
ما أعرفش بس أنا الكونكشن عندي كويسة.
الشباب بيقولوا أوكي هم شايفين.
لو الدنيا كويسة خلاص أوكي أنا I will solve my problem. ما دام الشباب شايف الدنيا كويسة it's okay.
أنا عبد الله علام. علام.
طبعا.
ازيك عبد الله؟
ده أول الناس اللي
وحشني حبيبي. أوكي. طيب قول لي بقى يا عبد الله، أنت شايفني وأنا بقلب كده السلايدز؟ يس اوكي.
طب خلاص يا فندم اتفضل حضرتك وانا هحل المشكله. اتفضل انا اسف جدا على الاسراف. اوكي.
طيب اوكي. So back again. Sorry for the interruption. Back again. We have in this view the flexion view, complete flexion view, to look at the articular cartilage here, and we said that the articular cartilage would look jet black on top of the bone. The only problem with this view is if the patient has a problem preventing full flexion, and I give an example. If we have big effusion inside the knee, he will not be able to assume this position. Next step. We are still in the anterior view, so we have seen suprapatellar recess with a quadriceps tendon. We have seen patellar tendon. And then we have seen with complete flexion the articular cartilage. Now with full extension, we check the parapatellar recesses. Those are extension from the recesses of the joints on the sides of the patella. So this is the patella. This is the retinaculum going to the femur, and this is the femoral bone. Of course, we have here the joint. So any black area here between the two folds of the retinaculum would be the recess. This is called lateral parapatellar recess. So we have taken one step before suprapatellar recess. This is the second recess, which is parapatellar, lateral parapatellar recess. Always remember the view in transverse. Okay, don't mix this with another view that we look longitudinal. Okay, here we have it transverse, the upper part of the probe on the patella and the lower part of the probe on the femur. And we look here, we see the patella and we see the femur, and here is the recess between the retinaculum and the bone. Here is an area of fluid. It's normal to see a little bit of fluid in the knee. This is the biggest joint in the human body, and we can have some fluid, and also just a tip. When you are beginning, you're a little bit nervous and you press too much on the probe, so you can also compress a fusion if you have one. So try a little bit to put thick layer of gel, reduce the pressure, open up the space, and check if you still have only mild fluid or no fluid. This is normal, but if you get more fluid, this is abnormal. Also, here is the place where we will check the synovial lining, because this area is intra-articular, so it must be lined by synovium going like this and folding back like this. And any disease that causes synovial proliferation will also appear here, whether with grayscale or with a Doppler. Can you see this, how we put the probe? We will just shift to the other side, like this. So we have the upper part on the patella and the lower part on the femur, but just on the medial side, okay? So this would be the patella, this would be the femur, and this would be the medial parapatellar recess. In this area, we have some prefemoral fat. In this area, we have the triangular suprapatellar fat. And here is the recess, and again, with little bit of fluid or without fluid at all. In fact, those recesses are very important together with the suprapatellar recess to assess the joint regarding effusion, hypertrophy, Doppler signal, and also injection. So, for example, myself, I always prefer to inject in the lateral parapatellar recess, because here, if you put the probe like this, so if you introduce the needle from underneath, I will show you another image. So the needle would come like this in this recess. We don't have to push the needle inside here. We just put in the recess, any area in the recess would take the fluid inside without having to manipulate this area. Because in the older people where we have osteoarthritis, this area is actually narrow and very rough and full of osteophytes and will hinder the needle, and you will do a lot of maneuvers until you get inside. And we do this in the blind injection, but when we have ultrasound, you have an advantage to see how the recess is easy to visualize, and even you can press with your other hand in the medial side here, so you can push a little bit of fluid to come in this area and open the recess for you. And if you introduce the needle in this recess, you are already intra-articular and there is no need to manipulate further down. Okay, this is lateral parapatellar recess. This is medial parapatellar recess. And by this, we finish the anterior exam. Now we will move to the medial exam. Always remember, we saw anterior, we still have to see medial, lateral, and posterior. Use the needle in this recess. You are already intra-articular and there is no need to. And lateral parapatellar recess. Also remember that you can what we are discussing now is very basic steps. You can take this presentation or lecture again in a higher level or more advanced level. So we will see more structures with more tips and tricks, but I am trying to make everything simple and clear. The next side we see is the medial scan. So we put the probe in the medial part of the knee, but remember, it is different from the anterior medial parapatellar recess. Just the previous one, the previous image, we had this parapatellar recess, medial scan. The probe is put transversely and is considered part of the anterior exam. But this area, it's a new exam. Now we are going to the medial side and we are seeing the joint longitudinally from the side. So we are expecting to see the proximal bone, which is the femur, and the distal bone, which is the tibia. And then in between, we see part from the joint, this area, And what we see here is the anterior part of, or the superficial part of the anterior horn of medial meniscus. What is above the medial meniscus is the medial collateral ligament, forming part of the capsular entity of the medial side. Of course, when we speak about the medial layers of the knee, it's a complicated issue, but just to make things easier, we say that the anterior horn of the medial meniscus is attached to the medial collateral ligament and then the capsule, and this forms the anterior part. That's why if you want to inject inside the knee, we don't prefer to go from here. This is very dangerous and destructive. If you hit the needle like this, you will hit the meniscus, and we only use this area for injecting the different structures that you can see. For example, the medial collateral ligament itself, any bursa around the ligament, perimeniscal cyst or around the meniscus. But if you want to inject intra-articular, the other approach I told you about, which we will see later, is more easy. This is a diagnostic view. Also remember, because when you get a case of knee pain, you also need to check this femur and this tibia for osteoarthritis or osteophytes, because if you have big osteophyte here, it will be pressing the medial collateral ligament, and this is the pain generator in this case. Beside the other symptoms or signs in the ultrasound for the osteoarthritis, it is very practical to check this area, because you can see that the articular cartilage, whether bad or not very bad, might not be the reason why the patient is having the pain. And a lot of patients would describe the pain in the medial side of the knee owing, one, to this osteophyte pressing the anterior, the medial collateral ligament, and second, distally here we see the epis and serine, whether the tendons, the bursae, or even the blood vessels and nerves. After this, we will do the same on the lateral side. So we go to the lateral scan to check longitudinally. So it's the same thing. We see proximally the femur and distally the tibia. And here we have the iliotibial band, which is on the lateral side. And we have the popliteus tendon originating from this groove on the femur. And this tendon goes intra-articular after this. This is a very peculiar muscle. It has a tendon that arises from the femur and goes intra-articular. And please, also a trick here, this tendon might appear anechoic because of anisotropy, because the tendon fibers assume certain direction. So don't always misjudge or jump into conclusion that we have effusion around the tendon or we have tenosynovitis. This might only be anisotropy. So check again the popliteus tendon and the iliotibial band. Of course, the iliotibial band at the insertion at the tibia will make fanning insertion, and this very important area to check for any irritating factors. Besides that, you can take it from here and go up to check the iliotibial band and the friction syndrome and the greater trochanter and so forth. Okay, so this was the medial and lateral views. And this is in details the iliotibial band and the fanning insertion together with the anterior horn of the lateral meniscus. Just like the medial side, we see part of the anterior meniscus, which is the anterior horn, part of the meniscus, which is the anterior horn. Here we see the lateral part, and on the medial side, we have seen the medial part. The superficial part of the meniscus has some anechoic structures like this. It can represent different things. Always put your Doppler on, because normally, even if the patient doesn't have any pathology, you can expect to see some blood vessels in the superficial part, and that's why they call it red zone. And sometimes you see perimeniscal cyst or meniscal tears or something like this. So be careful for the diagnosis. You can use grayscale, you can use Doppler, you can use compression, and check for any lesions or just normal feeding vessels at the top of the anterior horn of the lateral meniscus. Dynamically, this is a video, so I check the movement of the iliotibial band and the whole insertion, owing for or checking for any medial side. We have seen the medial part. Checking for any problems or irritation of the iliotibial band. After that, the patient would be lying supine, and then we would check the back of the knee, make sure the foot is outside the couch, and you have a straight knee, completely extended. And then here is the proximal part, and here is the distal part. And like always, this is the proximal part. So we see the proximal bone, which is the femur. And this is the distal part that we see the distal part here, which is the tibia. And then distally, we see part of the calf muscle, which is the medial head of gastrocnemius. And proximally, we see part of the hamstrings. This is a tendon of semimembranosus going down to insert in the tibia. And of course, this is medial head of gastrocnemius going up to insert in the femur. Here we should see a triangle, which is also the posterior part of the medial meniscus, the posterior horn of the medial meniscus. This area, sometimes referred to as the decussation between semimembranosus and gastrocnemius, is the area where we can see a Baker cyst, if it exists. Usually, the Baker cyst, if it does not exist, there is a small bursa called semimembranosus gastrocnemius bursa, located around this area, and usually not seen, or it might be very small. It doesn't bother you. The Baker cyst has to be big, because some people have asymptomatic small Baker cyst. It doesn't mean anything. But if it's big, it will show in this area. The area of interest for injections, whether the knee joint space from a recess, and we have explained that we have 3 recesses: suprapatellar recess, lateral parapatellar recess, and a medial parapatellar recess. Okay, sorry, this would be lateral, I guess. This would be medial, because this is the SGS. So medial and lateral and suprapatellar recesses. Also genicular nerves, and this is a funny thing, 3 versus 6, because as the name genicular, we only have 3, but some papers and some authors would like to call some other nerves by genicular, like middle genicular, which not a lot of anatomists would call it this way. But anyways, I mean the 3 main genicular nerves, and then 3 more nerves if you add them in the advanced levels. Also the bursae, whether suprapatellar, prepatellar, infrapatellar, and the Baker cyst, all of these are areas of injection potential, and also soft tissue lesions like cysts, ligaments, tendons, etc. And you have to be careful to choose the correct type of injectate each time, depending on the source of pain and depending on the condition, and depending also, most importantly, on the structure. So if you have a ligament or tendon without a synovial sheath and it's under strain and friction, probably if you inject this only steroids and repeatedly, you're weakening the tendon and ligament and potentially allowing it to be torn. Probably you should think of something regenerative. Okay, so it's always good to open up our minds for the injectate type. This is, for example, the type of, this is a paper talking about the nerve blocks. Here we have the genicular, the proper genicular. This is superior lateral, superior medial, and inferior medial genicular. And the paper describes how to reach them. And the nice thing is that they are always related to the bone and overlying muscle, the bone and overlying muscle, the bone and overlying muscle. So it's very easy when you go with the bony landmark up and the bony landmark up and the bony landmark down to get up to the nerve, and you can either inject. It's always good to open up our mind block, or you can always also either use local anesthesia with steroids, or even radiofrequency to block those nerves. And as I said, those are the preferred methods for blocking the nerves, but not necessarily the methods we use to inject other parts. Okay. So if you consider the 10 nerves, which is the higher version of the 3 and 6, it is supplied, the knee joint itself is the biggest joint in the body, and it's supplied by direct branches from femoral, sciatic, and obturator nerves. These are 3 separate nerves arising independently. And we sometimes divide those areas into anteromedial and anterolateral parts, or dividing into 4 quadrants. So superior medial, inferior medial, posterolateral, inferolateral, and then study each nerve in the area. And the posterior knee joint, which is usually sometimes neglected, is also supplied by 2 or 3 nerves, most commonly via the popliteal plexus. And I would say that this is quite advanced level of speaking about the nerves of the knee. The beginner would only locate the 3 genicular nerves, and then more advanced, we check another 3 nerves to be 6. And then if you consider the whole nerve supply of the knee, it would be 10 nerves, but a lot of them would be very difficult to visualize. Regarding the intra-articular anatomy, this is a scope, and you can see synovial proliferation inside the knee. So it is always good to add to your clinical examination, because you can see synovitis in 60 to 85%, and you can have this patient referred to you with knee pain. And then when you examine with the ultrasound, you detect intra-articular pathology of villus formation, for example, in a synovial thickening or effusion in the knee, and you cannot detect. Even if we see that the knee is a big joint, easy to examine, easy to detect, and our professors always teach us there's a lot of techniques and tests to detect intra-articular. You can never be sure, and the sensitivity would be at maximum around 80 or 85%, and you can miss a lot of pathology inside. So using the ultrasound can identify the exact lesion inside. This is another study that showed that 107 patients had clinically assessed for remission, and that a third of them don't have any painful or tender or swollen joints. However, 25 from the 31 had MRI synovitis, and 22 from the 31 had ultrasound synovitis. So compared with the MRI, we don't stand in a bad position. It's good, especially when you add Doppler signal to the ultrasound. You can compare yourself to the MRI, which is really more expensive, more difficult to perform, and time consuming with a lot of complications, or I mean contraindications sometimes, and not easy to repeat or to follow up with it. So if you can actually detect a lot or a comparable ratio, but look at this patient that had nothing clinically, but with MRI and ultrasound, you detect a lot. So to say that there's a remission in it, an autoimmune disease, you have to require imaging study. This is also another study. This time it is for the enthesis, and as we know, the enthesis is the area where the tendons and the ligaments are inserted in the bone. And this is an area where we have mechanical issues or we have inflammatory issues. So each time we examine the knee, we need to know where is the pain generator, what is the problem, what does the ultrasound give us beside the clinical examination and the history. Is it just pure osteoarthritis? Is it just pure accidental knee pain? Is it just mechanical or traumatic because he's sporty? Or we can detect more pathology depending on what we see. As we talked about the synovitis intra-articular, also this is the enthesopathy. And you can see that the dark arm, the ultrasound arm, is usually superior, very much superior on the clinical examination to look at the enthesis and detect enthesitis. And this is a very common area, because if you have this referred to you and you detect enthesitis, then you have to direct this for treatment or for diagnosis, because this is very important entity in rheumatology. Here we have a panorama image of the knee, where we have prefemoral fat, femur, suprapatellar recess, suprapatellar fat, quadriceps tendon, insertion of the quadriceps into the patella and the whole patella, then the patellar tendon insertion in the patella, and the distal insertion of the patellar tendon in the tibia. And this is Hoffa fat pad, and this is intra-articular space. So you have like a panoramic image. If we speak about the bursae, here we would have suprapatellar bursa. Here we would have pre-patellar bursa. Here we would have infrapatellar bursa, the superficial area. And here we have the deep infrapatellar bursa. And then at the posterior part here, we have the Baker cyst and the other bursae. There is a lot of bursae around the knee. Some are around the collateral ligaments, some are around the the patellar head and the insertion of the tendons at the back. So it's not only one site or one bursa per area. This is one of the biggest joints that has bursae around it. So the normal enthesis, as I explained, would consist of the distal part of the tendon and the insertion in the knee, together with this very fine line of the insertion. This is called enthesis, and this area is usually, even if we don't have enthesitis, which is inflammatory, we might have enthesopathy, which might be mechanical, degenerative, or some other types. And also, this is a common tendon to check for calcification in this area. Some sport injuries, we see it very healthy and sometimes not very old, maybe young, maybe middle age, and you can see calcification. The calcification is usually very painful, and it doesn't have to be destroying the tendon or showing other signs to be painful. And this patient complains of anterior knee pain, and with the ultrasound, you can pinpoint whether jumping or running knee or something like this. So again, this is the anatomy: the quadriceps tendon, the patella, the patellar tendon, the insertion, the Hoffa fat pad. Here we have the bursa, the deep infrapatellar bursa, and this is the recess inside the joint. This is the cruciate ligaments, and this is the posterior part. So this is like 3D example of the knee. Okay, so for the suprapatellar recess, parapatellar recess, intra-articular, Hoffa fat pad, relation to the intra-articular part, the posterior part, relation to the Baker cyst in this area. This is femur, this is tibia, this is patellar tendon insertion in the tibia. Okay. So, as you can see here, the patellar tendon in the patella, and this is the patellar tendon in the tibia, the distal part. And we have seen this part. If you go with the anterior hornomedial meniscus and the medial collateral ligament and trace distally, you can see the inferior medial genicular vessels and nerves and the medial collateral ligament and the pes and serine tendons. And this area is very important for many reasons. Either you want to block the vessels, part of blocking the knee pain, or you want to check the distal insertion of the medial collateral ligament. Yeah. Or you want to see tendon insertion in the pes and serine tendons, or you want to check for pes and serine bursa. All these are common clinical, and you want to check this area. All what you have done is putting the probe here over the medial collateral ligament and moving distal with the medial collateral ligament for the insertion, and it shows 1, 2, 3 structures that we need to localize. Also, don't forget the infrapatellar branch of the saphenous. The infrapatellar branch, the saphenous is just the distal continuation of the femoral. It's a sensory branch, and a lot of the anatomists would consider it the normal continuation, and some would consider it a major branch. It's a sensory branch distally, and there is a major one, the infrapatellar branch of the saphenous medially. And that's why injuries, operations, or traumas to the medial side of the knee would sometimes cause entrapment of the infrapatellar branch of the saphenous. So at least today we have said the inferior medial genicular, the superior medial, the superior lateral, and the inferior medial, and the infrapatellar branch. This is at least 4 nerves of the 6 or the 10 that you need to know. Some examples of basic knee pathology. Those are straightforward because of this is the patellar tendon. Here you can see that the tendon is thickened, hypoechoic, losing the fibrilla pattern, widely distended, not well demarcated, and there is no sharp outlines. This is the distal part, which looks better. We should see the whole tendon like this, but this area is affected. And if you put the Doppler in this tendon, you can see positive Doppler. Kindly don't assume this is an inflammatory condition. Don't say this is tendon. We say this is tendinopathy, tendinosis, فيها اعتلال في الوتر وليس التهاب بالضرورة. قد يكون, it might be inflammatory, وقد لا يكون, might not be inflammatory. It might be post-operative, might be sport injury, it might be traumatic, might be idiopathic or metabolic. could be inflammatory. So we just need to discuss and see the integrity of the fibrils, the thickness, the demarcation, the borders, the condition, the fibrillar pattern, the Doppler signal, and then we decide from here, based on the history and the other examination, what the patient has and how to proceed. At the distal part of the tendon, the patellar tendon, and near the insertion with the tibia, there is the infrapatellar bursitis, bursa, which is when inflamed, there's a bursitis. Also, a trick here that this bursa looks small on longitudinal fashion. So you have to look underneath the tendon in a transverse view to check how big the bursa. So this is not very big one. The big one would be underneath and full, and a smaller one would be just a teardrop here. So this is small or medium size. It's not so big. Don't count on the longitudinal view. Even the big one would look like this, but count on the transverse view because it can show you the whole size. Another area, this is the posterior. Remember the posterior view? This is the femur with the overlying cartilage, the tibia with overlying cartilage, the posterior horn of medial meniscus, the semimembranosus, the gastrocnemius, and the decussation. And remember this image, which tells you where to look for the Baker cyst, which is coming from the knee in 70% or 70-something%. It's communicating with the recess of the knee, and sometimes it's separate. Rarely it is not communicating. And even when it's communicating, sometimes they say there is a valve mechanism that prevents sometimes, but most of the time when you inject, the injectate would reach whether this way or that way. But be careful, because not every time you see a Baker cyst, you would like to jump into injecting. Try to diagnose the patient, because this Baker cyst is very, how would you say it, sometimes recurrent, and a lot of times is not easy to treat by aspiration and injection, and the patient keeps coming back, and sometimes you need to re-inject many times until it disappears. So you have to examine the patient and take some history to see, can it be a gout? Can it be pseudo gout? Is it inflammatory? Is it just mechanical? Is it osteoarthritic? Is it sport injury? Is it whatever? So not only when you see the bursa, you aspirate and inject, you need to diagnose it. This is another example. When you move your probe, you find the cyst part superficial to the medial head gastrocnemius, and part is deep because it's C-shaped. This is a transverse view where you can see the C-shaped bursa around the tendon. This is the medial head of gastrocnemius and the tendon going proximal. And this is the classical C-shaped bursa. So it has superficial part and deep part. And that's why also directing with the ultrasound, you can detect a lot of fluid. This is another example where you have intra-articular tissue, and you have intrabursal tissue inside the Baker cyst, and intrabursal synovial proliferation with Doppler signal. So this is not a simple Baker cyst that needs aspiration injection. Usually this is not also mechanical. So this patient needs to be referred to check what is the reason for behind the inflammation of the Baker cyst. So you have seen proliferation of tissue, and you have seen Doppler signal. This is inflammatory bursa. It is not just simple bursitis treated by aspiration and injection. This is an example of suprapatellar recess. Remember, femur, tibia, suprapatellar fat, and this is the quadriceps tendon in the patella. And this is the suprapatellar recess, but this time with a lot of fluid, not simple fluid. So this is another example of suprapatellar effusion or synovial effusion. Because remember, we have said that the suprapatellar recess, the medial parapatellar recess, the lateral parapatellar recess are the three recesses where you want to check inside the knee, inside the joint, how the joint is doing regarding effusion, hypertrophy, Doppler signal, any abnormal material inside the joint is checked on those recesses. Another example, this is left suprapatellar recess also, where we have synovial proliferation, and don't mix this with the normal prefemoral fat. This is synovial proliferation here and effusion. This is the parapatellar recess. This is patella, femur. This is the parapatellar recess, and all what I'm doing is I'm compressing with the probe in the transverse fashion. This is the retinaculum connecting the patella to the femur. And if you have an effusion here, if you press with a probe, you can compress the fluid and detect if it's a fluid or effusion, or sorry, or hypertrophy of the synovium, or is it just a small amount or big amount abnormally found inside the joint, and also direct the injection. In this time, same recess, but we have abnormal intra-articular material. Here, you can see synovial proliferation. If you put the Doppler signal, it would be Doppler signal positive. And of course, this is not a straightforward case that you want also to do probably rehabilitation, physiotherapy, or inject the knee. This is a disease that needs to be diagnosed first. So whether we have an inflammation, it's not a simple case of osteoarthritis or just a trauma. We need to check the history and examine the patient and complete the diagnosis before we intervene. It's another example of the articular cartilage. Remember, we had this black, jet black area here, the femoral articular cartilage. This time with the femur, the bone landmark, and also a thick line at the outer part. This is not normal. It was not like this. This is double contour sign of gout, where we have thick lines, both of them. We usually have thick line here, but not this one. But here we have two lines representing gout. This is the normal inner line, but we have crystals depositing inside the articular cartilage. And this is the other side of the coin, the pseudo-gout or the CPPD disease. The pseudo-gout is the other face of the coin for the gout, which is a crystal deposition disease. So this is gout, this is pseudo-gout. So it proves that this view that we are looking at the articular cartilage, we were not only looking for sign of osteoarthritis, we can also look at abnormalities like this to detect either crystal deposition disease, whether gout or pseudo-gout, in addition to the abnormality that you can see in the cartilage itself and in the bone, osteophytes, or in the soft tissue, irregular outer margin, and in the thickness of the cartilage, and in the echogenicity of the cartilage, because this is a hyaline cartilage. As it gets degenerated with time, it becomes void of water, and then it loses the jet black echogenicity. And the thickness would be variable between the areas. Here an example I told you about, the medial exam, where you see the medial collateral ligament and the anterior horn. This is the femoral osteophyte friction against the medial collateral part. So it's very important to move the knee and look at this area, because this patient, for example, doesn't have much problems with the articular cartilage, but he has an osteophyte here pressing against the collateral ligament. Here, we don't like to inject steroids intra-articular, and that's it. This is another management of probably regenerative tissue, a regenerative injection around here, or probably later when this is an extreme condition, surgical intervention. This is the normal injection I prefer. We put the probe on the upper lateral aspect. So the upper part of the probe would be here, and then the lower part here. And you inject underneath the probe from lateral to medial, checking the needle in plane. So this is the lateral parapatellar recess. And this is an example. This is the lateral parapatellar recess. And you can see that the needle is coming from the side in here. And you can aspirate the fluid and inject. This space is only about, over this length, 1.5 centimeters, maximum 2 centimeters, even in obese patients. And it's easy instead of manipulating in other sites trying to get intra-articular. So I am introducing the needle. Here it is. I can aspirate this fluid, and then I can inject inside, and very safe, away from the patellofemoral articulation that is full of osteoarthritis, and not trying to manipulate to get inside the knee joint. This is the injectate inside. And you can see everything with the ultrasound, so you can guide yourself. This is another example where you have a Baker cyst. Don't aspirate the whole Baker cyst after you diagnose this patient, and the reason for the Baker cyst, aspirate and leave a little bit of fluid so that the needle, you are sure that the needle inside, and this is how you see your injectate inside the Baker cyst itself and not outside here in the tissues, because you have some nerves and some soft tissue structures. So this is just an example of the types of injection. not everything, because in the PRP, this is allogenic PRP or autologous, this is autologous PRP, but you also have the growth factors, different types, powder or lyophilized growth factors, and you have the gel material for the surgical cases. You have hyaluronic acid when you have dry knee. You don't want to inject steroids so many times in a patient that is mechanical, osteoarthritic, old age, and will always do this injection. So repeated steroid is not the preferred way. But if you have a younger patient with some inflammatory condition, even with osteoarthritis, then you aspirate the whole fluid, you inject steroids to dry the knee, and then you proceed forward. Either this is a systemic disease, he or she will receive treatment, or this is degenerative disease, then you opt to one of those choices later. But if you inject PRP or hyaluronic acid into very big amount of effusion, I don't personally think this will solve the problem. And even if you aspirate the whole fluid, maybe next day you will have a major amount of fluid. So what I do personally when you have massive amounts of fluid, usually above 100 cc, sometimes 100, 150, 200, then you aspirate, you put steroids, and then 2, 3, 4 weeks later, when the patient gets better, you start your program, because these two are usually a program, not single injection. So you need to inject and follow up the patient and inject more and so forth. And sometimes the PRP is also painful. So in acute inflammation, the patient also has inflammation and pain and a lot of fluid. I don't prefer PRP. Then the choice would be steroids. For a dry knee, or even if we are injecting outside the knee when we have soft tissue, we will choose the type of hyaluronic acid that you can inject outside for the soft tissue, or you can inject PRP. This is autologous PRP, and this is a major study. You can spend one whole day doing a workshop on PRP and how to prepare, what is the different methods of preparing them, what are the kits used, and how to prepare in your clinic, and how to inject, and what is the protocol, and the different authors, and what do they prefer, and so forth. And there is a lyophilized types of growth factors. In this case, I don't prefer to say PRP. I would prefer to say, for example, lyophilized growth factor or something like this, depend on what factor we concentrated and we're injecting. It will depend on the condition. A lot of the references I used, I was humbly participating in. So this is soft tissue rheumatism in a book by Springer called musculoskeletal ultrasonography. My chapter is soft tissue rheumatism, and it's very difficult and explains a lot of the soft tissue structures that we talked about today. This is another chapter we wrote about osteoarthritis in comorbidity in rheumatic diseases, also with Springer. This is a third book regarding pediatric joints with pediatric musculoskeletal ultrasonography, and I wrote also the knee and the leg. And this is a YouTube channel with my name, Dr. Adham, one word, Dr. Adham, that you can follow some medical videos and some life coaching videos as well. And by this, I conclude my presentation today, and I am ready to receive your questions and notes. Thank you very much.
Okay, thank you, Professor Dr. Adham, for this. سامعني ولا لا؟ Okay, for this very, very, very exciting talk, and very professional and very simple and very. I'm sure everyone from the attendees does not want to be finished. So let me ask the first question, dear Prof.
Sure.
Some of the doctors say the ultrasonography is an operator dependent. So how can rely upon define this from different specialties? There is somewhat different visualization from you and another one. Some say there is a minor tear. Someone will know it's normal. How can you solve this dilemma?
Okay, thank you very much. It's a very important question, and I need all the colleagues to listen to this very carefully. When we move from this practical presentation into an academic one, we put a lot of papers that we have done longitudinal studies comparing inter-observer and intra-observer reliability of ultrasound. So the same examiner would examine many times and check reproducibility. And we can check similar or one case between me and my colleagues and check. Regarding the major anatomy and the main pathologies, there is a good inter-observer reliability or sometimes excellent or very good inter-observer reliability on certain conditions. First of all, we have to know that the musculoskeletal ultrasound has a long learning curve. So if we start today giving an image or getting an image, it doesn't mean we know everything. If we proceeded slowly and surely by many ways of learning, and I will explain now how to, for the long time necessary, probably we will reach the same point or point of view at the end. This is one. Second, the same type of structured training. Structured training means taking courses, going by steps, following guidelines of some school. So the Asian school, for example, works very potent anatomy. The European school goes by very simple procedure, 1, 2, 3 with rheumatology. Physical medicine has another way. The States work with another way, but we have to adopt one school, at least one, because maybe now we are studying each other. So after I finished the European school, I study now the American, the Asian, and take some good experience. So going in a structured way, not فهلوة بالمصري, a structured way.
Yeah.
Do not teach yourself the ultrasound. You have to go with a professor, with someone trusted with experience, and take the steps from basic to intermediate to advanced to interventional. Take some courses, attend, and don't think that only a YouTube video will teach you everything. YouTube video is good to ask for something, to check, but as experienced users, sometimes I go to the YouTube and I find accidentally some mistakes. So yes, check the YouTube, but also check your professor, go take a course, read a book, ask online, go to your professor again, attend some webinars, take a practical course again, and so forth. The third thing I want to explain that not only ultrasound is operator dependent, MRI is also operator dependent. Clinical examination is also operator dependent. Everything in life, is actually operator dependent. So we examine by different ways, different professors examine in different ways, see only what I want to see, what I know in my branch, in my specialty. And then, for example, I send to Abdullah because he has a different expertise. He's specialized in different part. He knows more information than the one I know in my specialty. So we form a team. And then I also send to the physiotherapy considered in this case. And he also has his own expertise seeing a lot of patients and rehabilitating a lot of patients and so forth. So we form a team, and each one in the team has a role. If we behave in this manner, we will get the best practice and the best diagnosis.
Yes, thank you. So the conclusion is you have a mentor. It must you have a mentor.
Yes.
You're again. زي ما حضرتك شايف, I think you see the questions in chat icon and also on Q&A.
I can see the chat. Is the questions and answers? Sorry.
Yeah.
Okay. Thank you very much. Can viscosupplementation and PRP be injected together? What is your experience? Honestly, personally, I don't like to mix injectates, but this is my personal opinion because I have read a lot of papers talking about injecting two things together. And more aggressively, even steroids with something, which I don't like very much because sometimes those PRP or viscous supplementation, they work on some cellular level in some hypotheses and some theories. So putting a strong anti-inflammatory might, I don't know, might stop some efficacy. It might give quick improvement because of the steroids itself, but it might block some improvement on the long term. Who knows? We need some good studies on the long term. But injecting two regenerative using PRP and hyaluronic acid is sometimes welcomed by some authors. Just not me. I don't like to do it. I have my own reasons. Some of them are like this. I have seen some rare reactions from hyaluronic acid. Very rare, maybe few in my life, but they are extremely aggressive. So if you inject PRP, we might think that this is the pain from the PRP, which usually the patient has for 1 week after injecting. But if after the hyaluronic acid you get pain, this is very unusual. This patient gets severe reaction, pain, swelling, hotness, redness. So we need to identify this very quickly and intervene. Another thing is, if you are building your own experience and database of patients on the long term, and you want to do an audit on yourself, forming a little bit of level 5 evidence, and then you do your studies, and then you start to move to level 4 and so forth, at least level 5 evidence, then you need to know what happened. You put two arms, one would inject only hyaluronic acid, one hyaluronic acid and PRP, and one PRP, or do some control. And then for a year or two, you do this, and then you get information. You have to be scientific in the way you behave. At the end, if you do this, I don't mind. So do one arm like this and one arm like this, and tell us the results after a year or two. By this, I build my own experience on getting a result on large amount of patients and saying which one is more successful. Oh, when I injected PRP with viscosupplementation, I needed less injection on the long term. Oh, when I did this, we needed the same time of injection. So why bother with PRP? Maybe only hyaluronic acid, or the opposite. So I mean, we have to be scientific. Losing the evidence this time, we have a little bit of evidence here and there, but only some small papers talking about combined injection. So this specific type is not forbidden, but build your own experience over the long time. And please come to me after a year and tell me your results.
Yes. What common interventions do you on posteromedial knee pain? This is a question from the same person.
Posteromedial knee pain, it might be a lot of structures out there. The one that is outside my scope, but I can detect is vascular issues. In this area, you can see aneurysm in the artery and also some venous malformation. So nullify those quickly, a DVT or something like this. So you need to do a triage for those cases, because you need to send them quickly to the vascular surgeon. Next, our specialty, where you look for pain generator, mostly the one that is very common and you see is the Baker cyst. So when you see a Baker cyst, don't quickly jump into aspiration and injection. Try to examine the whole knee, take some history, and decide which type. And sometimes we ask for lab tests even, or check for double contour or crystal associated arthropathy. So we want to pinpoint what is the reason behind this Baker cyst. And if you are assured and reassured about the disease and the systemic management, then aspirate and inject and be ready for physiotherapy later, or maybe repeated injection if you need to. If you are talking posteromedial about the deeper part of the collateral ligament, then this is a more complicated issue. If it's a strain, then probably I will not inject and I will refer for physiotherapy and rehabilitation. If it's not a strain and then we have bursitis, then we can inject steroids one time and that's it. But if we are talking about a strain of the ligament itself with osteophytes pressuring against it, you might thinking of injecting PRP or hyaluronic acid or some growth factors. If you are talking about some nerve entrapments, then a block with the steroids and xylocaine might be enough at certain point, and then follow up later, or some hydrodissection, for example, by either xylocaine itself, or even with saline or glucose 5%. So the area will depend which structure, which pain generator is causing the problem, and then you decide what to intervene with.
I think Dr. Tosher, a lot of what about the ablation of the genicular nerve? It is longitudinal in plane or out plane. Uh, you see the question, Professor Adam?
Yes, yes. Because for ablation, it's better to ablate large part of the nerve. Hence, it can be ablated in the same way as we block the genicular nerve. First of all, I have to say that I have so much experience with nerve ablation, but I don't do it. I don't work with radio frequency. I don't ablate the nerves, and I don't work as a pain management doctors as like this. I inject my patients only when they have a disease that belongs to rheumatology. When it becomes a pain management case, I refer it for other specialties. But I have a lot of experience with nerve blocks and ablations, and I would say that in some studies they do the like you said out of plane, and some studies they do out in plane. But I can see that with the new modalities, especially with the pulsed ultrasound, they don't have to ablate large segments of the nerve. And I have also seen some studies where they inject, and I've seen them live because the one who is doing it was my colleague. She was also putting the radio frequency probe on the capsule because they say that the capsular area is supplied by a lot of nerves, trying to reduce the number of radio ablation. Because if you ablate every nerve that supplies the knee, then you ablate from 3 to 6 sites, which is too much. And in this area, for example, they ablate the inferior medial genicular together with the capsular branch, and that's it. So it will depend if you are using pulsed radio frequency or no, and if you are using the ultrasound guided and not the cine guided, because the cine guided you can be in the region, but with the ultrasound you can be pinpointing the nerve itself. I think this is more accurate, and you will not need to ablate very large areas by moving, but only by locating and putting the probe directly on.
I think there is a last one from Dr. Omar Ahmed, I think from Iraq.
فين يا نجم في أنهي حتة؟
واحد الكويستشن. Yeah.
Do you need to stop aspirin before we go for radio frequency ablation? Also, does the conventional ablation damage vessels? I would like to tell you that it's very much easier to detect the blood vessels more than the nerves even with the ultrasound. So if you are using the ultrasound professionally, it's very easy to see the vessels easier than the nerves. And sometimes we locate the nerves by locating the vessels, either as pulsating or with a Doppler. So don't worry about the vessels, you will not damage them. But do you stop aspirin? If the patient is using only aspirin, I usually don't have to stop it. But with the radio frequency, I am not sure because they use probably a thicker probe and multiple sites. So I have to ask, or probably we can go with this question to people who perform radio frequency more often than I do. I usually don't do it. But I'm speaking about the normal injections. The normal intra-articular is a single injection, very thin needle, and we don't stop aspirin. What is your most preferred window among different recesses for the knee intra-articular injection? By far, it's the lateral parapatellar recess. It's more easy, more accessible, very small needle. You don't have to use large needles. There is less soft tissue structures in this area to destroy in your way. Not a lot of nerves and ligaments. Very easy to be intra-articular. It is the lateral parapatellar recess is the recess that has a lot of fluid usually. So if you don't have suprapatellar or medial, usually you have lateral. And also milking effect, you can press medial and gain a lot of fluid here. Easy to put the needle inside, whether for aspiration or for injection. So by far, lateral parapatellar recess using ultrasound is the easiest. In which condition of the knee pathologies you and local anesthesia. Well, I usually do this, or not me, like I told you, when we consider this case for pain management. So if we don't have any other ways of treating the patient, maybe patient going into complex regional pain syndrome, they need systemic treatment or injection elsewhere, as you can see the sympathetic block, and also around the pain generators and the genicular nerves. And also the late mechanical issues where the patient is unfit for surgery or is terminal cancer patient or so forth. These cases are considered probably there's nothing much that you can do for this patient as a systemic treatment, as autoimmune, as rheumatology. But if it's just pain management, then those patients I choose for blocking the nerves.
I think the last one from Dr. Azmi from Iraq. Can you inject steroids to diabetic patients complaining of the knee effusion?
You can do that, but you have to be careful to inject using ultrasound intra-articular and not peri-articular, and also to inject the minimum amount, because you know the knee can take 1 to 2 ampoules of steroids intra-articular by most of the authors, so stick to 1. And also instruct the patient that he should use the needle sticks to check his blood sugar more often in the 2 days after the injection, because even if you do all the precautions I mentioned, still this patient can get a little bit disturbed blood level, but it is not a contraindication for intra-articular steroid injection.
اوكي. كنا عايزين نحط البيج بتاع حضرتك هنا عشان زملاء كتير جدا من العراق يتابعوا حضرتك بقى في
هو موجود في الظهر اهو، انا عامل سكرين شيرنج موجود في الظهر.
احنا عايزين
فيسبوك facebook.com/groups/msus.egypt.
Anyone can join this page, and also Professor Dr. Adam weekly he do free webinars in different topics. At the end, I have no words that deserve your time and your a lot of these informations and expertise. Thanks, Dr. Azmi. رفع ايده.
sure. انا شايف سؤال تاني من دكتور تشار كمان. دكتور تشار بيقول when do you start strengthening exercises post PRP injection? Also, how many PRP injections do you recommend or prefer? الحقيقة, this is a big question and big subject. First of all, regarding the exercising, my own policy, after any injection, not necessarily PRP, I prefer to wait at least 2 weeks. But regarding how many PRP injections, it will depend on the way you create this PRP. If you are using like I use autologous PRP, that I use double centrifuge methods in my clinic, I prepare it. So I prefer to inject 2 to 4 injections and in between 2 to 4 weeks. But other authors have their own policy and their own program. And some authors go to 6, 7, and 8 times of PRP. I don't like to do this policy. And some other prefer to inject weekly, which I see also too much. My own way is I prefer autologous PRP, 2-stage centrifuge or double centrifuge, they call it, 2 to 4 injections, 2 to 4 weeks apart. And the physio would start 2 weeks after the last injection.
Agree. Okay, thank you, Professor Dr. Adham, for this excellent talk. Hoping to do another one.
It was a pleasure to be with you.
نعمل ايه؟ وكتر خير حضرتك. لو حضرتك عامل ريكوردنج للمحاضره دي يبقى كتر خيرك، لان انا لغايه دلوقتي الشاشه عندي مش شغاله، فتابعت حضرتك على اللايف.
لا انا ما عملتش.
انت حضرتك كان ممكن تعمل ريكوردنج، فهو
اسف لو كنت نبهتني في الاول، انا اصلي عامل نفسي مش ادمن بقى وعايش حياتي يعني. طب كنت نبهتني، طيب دي كانت محاضره حلوه والله.
لغايه دلوقتي كانت خير. شكرا جدا يا فندم.
هي حلوه بيك، وانا اقصد لان انا مبسوط من التفاعل والكويستشنز والكومنتس وكده. That's why it was nice, not my presentation. I say it a lot of times. I don't see anything superior. I see that your questions were very nice.
Yes. Thank you again, Professor Dr. Adham. نشوف حضرتك على خير. الله وجزاكم الله خيرا.
شكرا جزيلا دكتور نجم. شكرا. Thank you for everyone. Thank you.